see these mothers and parents and you have any hints that it could be herpes simplex, you need to make everybody horrified. You need to have these babies seen and assessed clinically.
People haven't seen enough of it to have it in their mindset when they see a sick baby. So there may have been a history of exposure from the mother, from the grandmother, from anybody. There may have been a history of exposure, but people haven't asked.
Hi there, I'm Emma Lim, a consultant paediatrician at the Great North Children's Hospital. You're listening to the Paeds Round, a monthly podcast from the Royal College of Paediatrics and Child Health. Every month we invite experts to answer important questions on the issues that matter in paediatrics, from areas as wide-ranging as obesity to social media. So thanks for joining us on our rounds. This is our second episode of our special edition on herpes simplex or HSV. And it is my great privilege to have our next speaker here with us, Dr Hermione Lyall. And Hermione is going to talk to us about maternal to child transmission of herpes simplex virus. Hermione, would you like to tell everybody what you do and where you work?
I'm a paediatric infectious diseases consultant, and I work at St Mary's in London. I have been doing this for quite a number of years, and I have particular interest in congenital infections and trying to prevent mother-to-child transmission of congenital infections. And that includes a number of viruses and also bacteria, and of course, HSV.
Thank you. I always feel that viruses are somehow underrated and underappreciated.
Okay, so I think one of the biggest issues here, and we're really talking about neonatal herpes simplex, infection that comes on in the baby after it's born, rather infection that it's actually had in utero for some time and that it is born with, which is congenital herpes simplex, which is exceedingly rare. And I have looked after 2 children with that condition over the last 25 years. And that is devastating destruction of the brain and other organs by the infection. But that is an extremely rare presentation of herpes simplex.
So Hermione, we're talking about 2 different scenarios here. Congenital herpes simplex, which is devastating and very rare, and neonatal herpes simplex, which you're going to tell us more about now.
So even neonatal herpes simplex is still a rare condition. And this is one of the biggest problems, that people haven't seen enough of it to have it in their mindset when they see a sick baby. Neonatal herpes simplex has been increasing, and Katie can tell you more about the latest BPSU survey. But, it's still only somewhere between maybe 5 or 10 babies per 100,000 live births. So that means that most pediatricians, unless they're in a very specialized unit, will not see a baby with neonatal herpes simplex during their training.
And so for these rare occasions, and I think it is really hard to remember this, what do you want them to think about and ask about?
So we want to think about women who are pregnant. Now, unfortunately, if you look at it from the baby's end, about 80% of the time when a baby has neonatal herpes, nobody has picked up that the mother had any symptoms or that there was a risk of infection. And indeed, the infection doesn't always come from the mother. In somewhere between 10% or maybe even up to 20%, the infection may have come from someone else, whether that was a healthcare worker or a family member or somebody else who has been involved with the baby. So the classical thing that people get taught about is a woman delivers with lesions, ulcers, or vesicles at the time of delivery. And there you think, oh my goodness, could this be herpes simplex? But the chances of that happening are actually extremely rare. And even if a woman has herpes simplex at the time of delivery, she may have no lesions at all. She may be systemically unwell. She may not actually develop the lesions until a few days later. She may have very painful vaginal grazes or symptoms a few days after the delivery. And people may be saying, oh, this is thrush or this is bacterial infection. And because they don't see blisters, they don't think of HSV.
All right. So you were right. All neonatal illness starts in pregnancy. So we need to be really mindful of thinking about asking mothers about any rashes they've got, any blisters they've got, any blisters on their fingers, as well as in their vulva or vagina. But more importantly, what you're telling me is that most of the time, these babies turn up with very non-specific symptoms and really no history of being exposed to herpes simplex virus.
Well, even worse than that, people don't ask. So there may have been a history of exposure from the mother, from the grandmother, from anybody. There may have been a history of exposure, but people haven't asked. And they may not have asked the right question, because the mum may have been really sick with a high fever and very unwell, and it's all assumed to be bacterial infection, but it could just as easily be primary herpes. That's just the situation if you're really looking at it around the time of delivery. But we also have to think about the weeks and months before that. And if a mother has herpes simplex genital infection in the weeks in the third trimester, so say after 28 weeks, her baby is still at risk because it takes a bit of time to produce an antibody response. She needs to be treated. She needs to be referred to the GUM service. She needs to get onto acyclovir, and she needs to stay on acyclovir until the time of the delivery. And indeed, if it's later in that third trimester, she should be offered a Cesarian section.
Is there a difference between women who are meeting herpes simplex for the first time and a reactivation?
Okay. Well, it's not straightforward either. So if you had your first herpes simplex earlier in that pregnancy, and you could be having a reactivation, your baby is probably still a bit more at risk. So you needed to have been treated then. And you also needed to have been offered the opportunity to go on to prophylaxis in good time for the delivery. The current RCOG and BASH guidelines only suggest going on to prophylaxis from 36 weeks gestation. But there are two really important points here. One is that herpes simplex itself increases your risk of having a premature delivery. And in addition to that, the babies who become sickest and are more at risk of dying from herpes simplex are premature babies. So in our view, actually women should be offered to go on to prophylaxis from much earlier. There's a recent Ugandan study which looked at this, and in that study, women went on to treatment from 28 weeks. In the original studies, women who had antibodies, protective antibodies, their babies had a much lower risk of complications. But I don't think it's necessarily so easily black and white. And I think women, especially women who've only had herpes simplex in the last year or two, they need to be offered, they definitely need to be offered prophylaxis.
So the Royal College of Obstetricians and Gynecologists guidance and the British Association of Sexual Health and HIV suggests you should start acyclovir prophylaxis from 36 weeks. But we know that acyclovir is safe, it's relatively easy to take, and it could prevent devastating disease and death, like we've heard from Sarah. Why do you think that people aren't offering prophylaxis more often?
So I think, firstly, they don't ask the question. So they don't ask if women have had genital herpes or not. Secondly, as we said, there are plenty of people who may have had genital herpes and they didn't know it. I think uh, I think we don't routinely check women's serology, and it would need women to be referred to GUM to actually have this properly assessed, which I think very rarely happens.
People don't want to disclose it. You must remember that sometimes people's partners don't know that they have genital herpes. And I also think in the general public, there is not an understanding that this is a treatable condition and that this may cause illness in a neonate. So I think these things are really not well understood. I think you've put how difficult the situation is in diagnosing and treating herpes simplex in pregnant mothers. But when it comes to it and you're faced with a child who potentially has it, what should we be thinking about at that point? And who should we suspect of herpes simplex infections?
Okay, so I am going to just use some cases that I've been involved with, which I think are very clear examples of where we can think better. So here's a baby who was born normal delivery to a teenage mum. And bear in mind, actually, teenage mums have a higher risk of having herpes simplex as a primary infection. Normal delivery, everything was fine. At about 4 or 5 days, the baby was noted to have some crusty lesions on the head. It was taken to primary care. A diagnosis of Staph aureus infection was made. The baby was started on flucloxacillin. New blisters and crusty things continued to appear, and a couple of days went by, and it wasn't really improving. Then it just gradually settled down. And a few days after that, the baby was found in status epilepticus and was admitted to intensive care. And this baby had devastating brain damage from herpes simplex encephalitis. The baby has forelimb cerebral palsy, is cortically blind, and his life has been changed completely. Now, if that person, that first person who saw those crusty things on that baby's head, had thought, this could be Staph aureus, but it's a presenting part with crusty lesions and maybe some little blisters, this could also be herpes simplex. If that person had thought about that and admitted that baby and done the investigations and started that baby on acyclovir, it's quite possible that that baby would only have presented with what we call skin, eye, and mouth disease and would not have gone on to develop encephalitis with its devastating outcome.
as a quick summary, when is the highest risk period of being infected with herpes simplex virus during your pregnancy?
I mean, I think the most dangerous time is where the maternal infection happens right at the end of pregnancy, so that the mother is viremic and there's a placental transfer of virus, or the mother has lesions in the birth canal and the baby picks them up at the time of delivery. So this is the most dangerous time.
And you said teenage mothers were more at risk of herpes simplex virus. Who else is more at risk?
So young women, women with HIV also are more at risk. And also depends on your ethnic group. There are some ethnic groups that are more at risk as well. So young women, Afro-Caribbean women also. But fundamentally, it's all women who are having sex. So, and because it's a very rare condition, you have to think about it for everybody.
And let's face it, if you're pregnant, you must have had sex at some point. Just as a summary, you and I think about acyclovir like vitamin A, like who shouldn't take it. But what are your recommendations?
So my view on this would not be the same as the current RCOG and BASH guidelines, because I think if you have a woman who presents with herpes simplex for the first time in pregnancy, you should probably go on to acyclovir from then and continue on it right to the end. If you have a woman who's recently become infected or who for some reason is diagnosed to be infected, um, she should start on the treatment, especially if it's beyond 24 weeks gestation, and stay on it.
And I think that, as you say, taking acyclovir, it's not unsafe, it's not going to harm their child. I think there are very few reasons not to.
Yeah, and actually, we would normally give valacyclovir, which is the prodrug of acyclovir, and only has to be taken twice a day. And the dose that you would use for prevention of herpes simplex is very, very well tolerated. But obviously, women need to be advised to keep well hydrated because, you know, it's renally excreted. So you want to make sure that they are in a good hydration state.
Okay, so my last question is, of course, Cesarian section. So talk to me about the risks and benefits of Cesarian section in mothers with herpes simplex virus.
So the classical situation is if you have a woman who's found to have vesicles or ulcers at delivery, and it's considered that she's having primary herpes at the time of delivery. Trouble about that is that you have to go on your clinical expertise, because you won't have time to send a swab to the lab and you won't have time to check the mother's serology. So you have to make a clinical decision about that. And as we said, very often women don't have obvious genital lesions. So making that diagnosis of genital lesions at delivery is really difficult. In addition to that, if the membranes have already ruptured, the longer they've ruptured for, then the less likely the baby is going to be protected. So people do say that if the membranes have ruptured for less than 4 hours, that it's still reasonable to do a cesarean section. If you know a woman got primary herpes a few weeks before, in the third trimester, then you would definitely want to offer her an elective cesarean section. And she should obviously also be on her acyclovir prophylaxis. If you have a sick woman at the time of delivery and you're worried that she could actually be viremic with herpes simplex, then you should be offering that woman to be on intravenous acyclovir. So there are all these different kind of nuances to it. And what it really means is that you need very good interaction between obstetrics, midwifery, virology, adult GUM, neonates, PID. Everybody needs to be working together, putting their heads together and thinking.
But yeah, I think that's so important. So you've talked about the risks in premature babies, you talked about premature ruptured membranes, and you've talked about really sick women who could be viremic, women who have had really recent herpes simplex virus infections, and the need for them to have really joined up care between all these different departments. Do you have 3 top tips for us?
Okay, I think the most important thing is that if you have a woman who has severe pain in the vaginal area, a woman who is unwell, and everybody thinks, oh, she's got group B strep, but the cultures are negative. If you've got a woman who has new lesions in the 3rd trimester, around the time of delivery, or after the delivery, you still have to know that there is a risk to the baby of herpes simplex infection. So it's always putting the kind of bits of the jigsaw puzzle together. And it's asking that question to the woman herself about exposure and to the neonatal team and to the kind of obstetric team. People have to think about it. The particular things that make me worry is any baby with abnormal LFTs, any baby in DIC, any baby with abnormal neurology. All of these babies should be given acyclovir until you've either proven something else or you've got HSV. We should also be making sure that we get rapid test results. So we should get BioFire or rapid PCRs back on the CSFs from these babies. And like you said, you need to send a blood PCR. But we can get rapid results, which is really helpful.
I think that this is really important. First of all sick babies deserve the right to have some acyclovir. The other thing for me is your last point is that it's quite easy to start acyclovir, but it's really hard to make the decision to stop. And we will never know if we can safely stop if you haven't sent tests off. When you see these mothers and parents and you have any hint that it could be herpes simplex, you need to make everybody horrified. You need to have these babies seen and assessed clinically. You need to have done all these investigations and possibly started them on acyclovir before it comes to the stage where it's irretrievable. Thank you very much, Hermione, for a fantastic episode. The Royal College of Paediatrics and Child Health, British Association of Sexual Health and HIV guidelines for the management of herpes simplex in pregnancy and neonates are currently out to consultation. There is some changes, and in it the advice for prophylaxis in pregnancy has been updated to please start acyclovir from 32 weeks generally or 22 weeks in any woman where there is a suspected risk of prematurity. For more information, please look at the www.bashhguidelines.org.
This podcast is a collaboration between Medisense Medical Education and the Royal College of Paediatrics and Child Health. You can find more creative learning resources on www.medisense.org.uk and of course a wealth of information on the important work of RCPCH on rcpch.ac.uk or #ChoosePediatrics.
The views, thoughts and opinions expressed in this podcast relate solely to the speaker and not necessarily to their employer, organisation, the Royal College of Paediatrics and Child Health, or any other group or individual.